by the Cost Action European Burden of Disease Network, where we will present you some inspirational examples of national burden of disease studies from across the globe. The European Burden of Disease Network is a networking it's a network of researchers and individuals interested in burden of disease assessment, with burden of disease being defined as the use of DALYs, disability-adjusted life years, to quantify the health impact of diseases, injuries, and risk factors. We organize meetings where we can learn from each other. We have possibilities to exchange researchers, to go from one institute to another to work on a dedicated project. And we also try to organize workshops and other presentations during meetings. If you want to learn more about our cost action, please feel free to have a look at our website. If you want to become a member, if you're not yet a member, then also have a look at our website, where you will find more information on how you can sign up and start receiving our newsletters and other news about our activities. So today, as mentioned, we will make a small tour of the world where we will have 5 interesting presentations from researchers involved in setting up and performing national burden of disease studies within their own countries. So we will go to Scotland with Ian Grant, France with Anne Gallet, Italy with Lorenzo Manasta, South Korea with Professor Yoon, and finally Australia with Michelle Gourley. So we will start the presentations following the order that was in the schedule. So starting with France with Anne Gallet.
So good afternoon.
Hello.
So I will, yes. Do you hear me? So good afternoon. Information on disease burden. May I have the second slide, please? So information on disease burden, risk factors, related healthcare costs and their variations over time represent a major concern of public health decision makers. The KNBD study is an extremely structured process with extensive global collaborations. It provides estimates to quantify health loss and disability from hundreds of diseases, injuries, and risk factors in about 200 countries, allowing benchmark and comparability between countries. However, health condition varies between geographical area in countries and subpopulation groups. These variations are due to different behavioral factors as well as environmental determinants. In the aim to define priorities and prevention strategy to improve public health, subnational estimates are needed. The aim of the French burden of disease study is to provide national and regional estimates taking into account social disadvantage and inequality of health. Next slide, please. The French National Health Insurance and Santé Publique France decided to pool their strengths and mutualize their resources in an objective of national coherence and for producing burden estimates. Even the objectives of both institutions are different. They contribute to the evaluation and definition of the health policies. The Health National Insurance, the main public French national health insurance scheme, provides healthcare coverage of the population living in France. They manage the National System of Health Data, the SNDS, one of the largest healthcare claims databases in Europe. Santé publique France is the French national public health agency, center of reference and expertise in public health. The agencies exist to protect and to promote the health population by relying on 17 regional operating units. The agency's missions focus on three main areas that are anticipation for identifying health risks, understanding for gaining a better understanding of the state of the population health, behavior and risk. And finally, third, action for devising prevention and health promotion strategy, training and implementing prevention program and responding to health crisis. Next slide, please. The monitoring of the population health is based on multi-source approaches and complementary data sources. First, the National System of Health Data, SNDS, managed by the CNAM, is one of the largest healthcare claims databases in Europe. The SNDS contains data for almost all the French population, including vital status and exhaustive information on pharmacy claims, and the type of outpatient services or procedures reimbursed. It also includes inpatient diagnosis and procedures, cash payments related to disease, disability, and medical causes of death. All data are anonymous and individually matched. Undiagnosed and untreated patients are not included in the SNDS database. The second type of source for the multi-source approach is the population-based studies with or without clinical exam, and population registers. And third, finally, there are specific population study, mandatory or syndromic surveillance. Next slide, please. However, the health insurance database has not been conceived for surveillance purposes, as the diagnoses are not registered in reimbursements of prescriptions or medical acts. Case identification needs algorithms that are built with clinical experts. And these algorithms need to be validated to make sure that we measure that what we measure is what we want to measure. And those algorithms need to be validated. To do that, we perform it with gold standard database that more often are registers for population or population-based study. And finally, of course, we perform sensitivity analysis of those algorithms to evaluate the quality of the algorithm. Next slide, please. The SNDS is a national and exhaustive for the captive population with national personal identifier. This allows training of individuals over time in the hospital discharge database and allowing follow-up to assess quality of care, readmissions or diseases complications. Individual matching between databases is possible with the personal identifier. It allows to enrich information with behavioral, social, and other non-health data. Next slide, please. Here is an example of the indicators we can produce from this multi-source approach. Cardiovascular disease is the second leading cause of death in France and the third leading cause of premature death. Here we describe the departmental disparities in premature mortality for all CVD, especially for stroke and myocardial infarction, taking into account the age of death. Between 2013 and 2015, premature mortality from CVD in France represented 8.9% of overall mortality from CVD. The average number of potential years of life lost prematurely, that is YLLP, per CVD was 10.4 years per person. Significant territorial disparities in prematurity mortality from CVD persist in France. Overall, the northeast of France, as well as the overseas departments, had a higher number of YLLP than the national average level. By contrast, several departments in two regions, Île-de-France, it is around Paris, and Auvergne-Rhône-Alpes in the Middle East, had lower YLLP rates than national average. These disparities are consistent with the distribution of modifiable cardiovascular risk factors and should support the strategy for action in prevention. Next slide, please. Here, we can see territorial disparities in standardized incidence in mortality ratio of lung cancer in women between 2007 and 2016. The geographical variation is different than the variation of CVD. The higher impact are in northeast and the south regions, and possibly consistent with the smoking behavior in women. These results have given impetus to preventive actions in favor of smoking cessation aimed at women. Next slide, please. Due to the COVID crisis, several activities have been discontinued in 2020, including the French BOD program. With the duration of the epidemic crisis, we have readjusted our program and restarted the BOD project. The national strategy relies on the opportunity, in one hand, of the European project that are several joint actions, as well as the cost action, the e-burden actions that allow exchanges between countries, compare methodology, and allow capacity building. In the second hand, we like to continue a collaboration with IHME to produce comparable estimates for GBD, to improve data accuracy for GBD estimates, and to produce a set of first subnational indicators. In the same time, the French National Health Insurance and Santé Publique France want to increase their own capacity to develop BOD indicators in a larger program, including the promotion of the evidence-based intervention for prevention, to evaluate the return on investments, and finally, to evaluate the impact on health improvement. Thank you for your attention. I'm sorry for the sound, but I can't hear anything.
We will be happy to read it out loud and ask Anne to provide a reply. In the meantime, I also had a question, Anne. At the moment, how many people in Santé Publique France are already working on the National Burden of Disease project? There's some delay on the line, so I don't know if Anne could.
Maybe it's a delay or her computer, he cannot hear. Maybe it's better to write on the chat.
Yeah. Okay. Okay. So yeah, and thanks Hannah for the nice comment. So you said that this is indeed a great example for many other countries. And we hope that the other presentations that we will have today will also prove to be nice examples. So maybe Anken can provide her answer later on through the chat. So I suggest, for the sake of time, that we continue with the program, and that we then now move to Italy, where Lorenzo Monasta will present us on the Italian GBD initiative.
Mainly on the Global Burden of Disease initiative. Well, our experience started in 2007, 2008. There were two Italian groups involved, of researchers involved in the early GBD, and we at the Maternal and Child Health Institute, Burlo Garofalo in Trieste, were in charge of estimating globally the burden of otitis media, which we then published in 2012. There were 11 Italian researchers involved in the first capstone paper published by IHME in 2012 in The Lancet related to the GBD 2010. There were 6 researchers from the Mario Negri Institute, mainly involved in CKD, 4 at Burlo Garofalo, and 1 dermatologist, Luigi Naldi. And then in 2015, we started discussing with IHME the possibility of actually pulling together the Italian researcher to create a network and work together. And that happened in 2016, thanks to Giancarlo Logroscino, who hosted us in Venice. Why did we do that? Like, we all believed in the GBD potential mainly for planning and prevention, but also for research. We think the GBD is the most complex and comprehensive effort ever to actually collect and weight evidence, elaborate models, and it creates a unique link among different measures such as incidence, prevalence, health system performance, sustainable development goals, and so on. But it's also great for research, like analyzing GBD estimates opens a lot of hypotheses for research, and then it allows us also to identify weaknesses in current data. So that's a lot of work to do, a lot of good perspectives. And we thought that working together and not as individual researchers was a good idea for improving the estimates, not only for Italy, but globally. So we now work together, we share experiences, we strengthen the exchange with IHME also. The fact of working as a network allows us to spread results more efficiently, and to push for GBD estimates to be used also as instruments for planning in Italy. It also allowed us to improve our sharing of data and information to feedback the system of generating estimates, and so this, as a consequence, to generate better estimates. And then it also allowed us to undertake this subnational process. And as you know, Italy is quite heterogeneous from north to south, and having estimates at regional level is a great thing for actually identifying social inequalities. So finally, in November 2018, IHME agreed to generate subnational estimates for Italy. In January this year, we got together, we carried out a 2-day workshop to evaluate preliminary subnational estimates based on GBD 2019, which are the estimates which will be published in 2 days, in the day after tomorrow. And but we are not ready yet. So subnational estimates for Italy will be released in 2021. So for the GBD 2020 exercise. These estimates, however, the GBD 2019 are already available for GBD collaborators, to GBD collaborators. So who we are now in October 2020, we are more than 70 collaborators, almost 80 from more than 20 research institutes, which comprise research institutes, regional health authorities, national research centers, such as UNAIL, the National Institute of Health, the National Institute of Statistics, and then there are universities and university departments and provisional health authorities. Not all researchers participate with their institution, but some institutions are actually involved officially in the group. And as we are many, we divide ourselves in core groups, depending on our knowledge, expertise, experience, so that we now work as a network, but also in different groups. And this is a lot more efficient, considering we are now a large group. So what we expect from the network and from GBD collaborators to increase our understanding, improve our understanding of GBD methods, which are quite complex, to devote time for the revision of estimates and articles, which is crucial, to always verify the sources which are used by the GBD to generate estimates and see if there are better ones, provide data that could improve estimates. Where's the presentation? Okay, so back on again, sorry for this. And so we want everybody to be familiar with GBD tools to visualize and extract estimates for analysis, to produce articles from GBD estimates and involve the national and regional levels. We already have some region participating actively in GBD. So the positive and negatives, well, ours is a bottom-up approach. We're not starting from the government level, and that's good for some aspects and bad for others. The good and bad is also that we are a large group, so it's difficult to manage, but we can cover a lot of aspects of estimates. We are starting to have contacts with national partners who are actually already aware of the GBD and want to be active part of it. We started seeing that the GBD is being part more and more of the national epidemiological lexicon. So people talk about the GBD more and more. And then the great thing is being part of the cost action and the WHO Europe disease networks, the European burden of disease networks, which are crucial for us because it allows us to compare our experience with experience of other countries. And this is really great. Okay, sometimes we find it hard to explain the GBD project as an open collaborator, especially in institutions. Institutions that tend to be quite conservative, and this is also reflects in the difficulty in reaching institutional data. But of course, like the Ministry of Health is aware that we are working on this and allows us to actually have access to national discharge records, which have been very helpful for them to improve actually IHME GBD estimates. It's difficult to have all collaborators participate actively, but we try to have them all participate actively. And we had difficulties in finding a method to tackle the review of preliminary subnational estimates, which is quite a complex task. So where we are now, we have published last year a paper on Italy's health performance, 1990-2017. And then the group of La Bicocca published a focus on cardiovascular diseases. There are other papers we're working on, one on cancers, coordinated by Cristina Bosetti at the Mario Negri Institute. There is another one on neurological disorders coordinated by the Institute, the Besta Institute by Alberto Raggi. And then we are working on a series of other issues and analysis and articles. It's important for us now to actually set up a core group also of regions to work on local, on subnational estimates and planning, which is carried out mainly at regional level. And of course, to share our experience with other countries, which is fundamental. Thank you all. I don't know if there are any questions.
Thank you, Lorenzo. I do have a question.
Yep.
Could you elaborate? You mentioned that the Ministry of Health is using the results. Could you elaborate a bit more on how they are using it? What are the interesting parts for the policymakers?
I didn't say they're. Can you hear me? I didn't actually say that they're using it. I said that they're aware of us and they allow us to access data. I'm not aware of their use of the GBD estimates. I think they're using it. I don't know, however, at what level they are. We are more aware of regions who are using GBD estimates. We're in a difficult situation now with COVID, of course. So since January, things have slowed down quite a lot. But regions are willing to use GBD estimates in their planning, especially Toscana, Emilia-Romagna, Sicily, and now Lazio also.
Okay, thank you.
Welcome.
I'm keeping an eye on the chat as well. People, if you're in the audience, if you have a question to Lorenzo or the other presenters, please use the chat to ask your question. I don't see any other questions. So thank you, Lorenzo, very much for your interesting presentation.
I'm here anyway.
Yeah. You're not going anywhere either. Okay. And then we are going to the next presentation. That's Ian Grant from Scotland, I think. Ian is there. He is there. Okay, Ian, the online floor is yours. I don't see Ian.
Can you hear me?
Okay. Oh yes, Ian. Now I can at least hear you loud and clear.
Yeah. Right. Okay. Sorry. Yeah, my video is frozen. My broadband connection is not so good. I will carry on talking if that's okay. Yeah.
Yes, please start with the interesting case of the Scottish burden of disease study.
Right. Thank you. Good afternoon, all. This afternoon, I'd just like to discuss how the importance or the power of administrative data in carrying out a national burden of disease study based on our experience in Scotland. In 2013, the Scottish Burden of Disease Study set out with an ambitious aim of comprehensively estimating the burden of 132 causes of ill health and mortality using a wide range of administrative data available in Scotland. I mean, this was carried out as an independent national burden of disease study. However, we still drew on some of the GBD methodology, particularly for disability weights. So over the next few slides, I want to reflect on our experience, highlighting the advantages and limitations in our approach. So in our study, we utilised the rich and widespread data which is recorded through individual encounters across the universally available and free at point of contact healthcare services in Scotland. This is important as it gives us near full population coverage. And from these data sources, we are able to extract a lot of individual information items such as age, sex, geographical residence, and very importantly, socioeconomic status. This information is available from a wide range of data sources, including our death register, our primary care, contacts with our general practitioners, secondary care data sources covering inpatient, outpatient attendances, and other contacts, as well as drawing on specific disease registers like our diabetes register, and including long-standing national population health surveys as well. And by linking these records across data sources using identifiers, we can look at individuals' health experience from virtually birth to death, stretching back over approximately 40 years. This has allowed us, in terms of population health monitoring, to produce estimates of our DALYs, YOLs, YOD, both at national and local level, and to look at what we call intersectional effects, such as the effects of socioeconomic status. Now, the benefits we've found of using this administrative data is it's allowed us a large degree of autonomy to decide and target what our analysis should be and what our output should be. It has allowed us to align much better with the demands of national and local policymakers. And this has been particularly important in terms of supporting the health inequalities agenda in Scotland, which is very prominent. It's also allowed us to be very transparent about what our data sources are and what the limitations are in those data sources, as well as the advantages. It has allowed us some understanding and control over our data, over uncertainties around data, and the methodological choices that we make when we estimate our disease burden. It's worth reflecting just on some of these ones because these are quite important. Certainly, using our administrative data, it's allowed us to get recognition and endorsement of the numbers that we are generating from these data sources from our key stakeholders. That could be at a national level or a local level, or indeed from clinicians who have been supporting our work over the years. Equally, it's helped us co-design outputs to meet stakeholder needs, whether that's at a national level, at a local level, or whether that's through the development of dashboards and how we go about presenting that information. In terms of methodological choices, it's allowed us to avoid some of the generalizations that you could find within the GBD approach around, for example, generating health state prevalence. An example I could use about that is using our data sources, we've been able to generate specific severity distributions for some of our conditions, such as cancer. It's also given us an appreciation of some of the real differences in terms of the data inputs that you put in. So it's allowed us to play around with these and to investigate the effects of these. For example, the GBD produce a lot of the results through using the world standard population. We've been able to look at the differences if we use a European standard population. And equally, when it comes to redistributing ill-defined deaths within a burden of disease study, we've been able to use our own information from our own death register to develop a more targeted approach based on our own death data to redefine those deaths in a more accurate way. And indeed, we've found some significant differences when we've taken these approaches. If you're interested to explore these, we have some references at the bottom of the slide to allow you to look at these in a bit more detail. In doing this, it's allowed us to have a better appraisal of GBD estimates. I mean, we still look at them, but it allows us to understand the estimates they're producing and where our estimates may differ or may coincide with those, which allows, again, us to be relatively confident or not confident about the administrative data source we're using. It allows us, essentially, to sort of occupy a middle ground, really, between complete independent study and collaborating with the GBD. Of course, it's not all plain sailing, and there are limitations of using administrative data. One aspect of this, particularly when we're linking health records and getting access to these health records, is that data governance can be an extremely time-consuming activity, particularly at the outset of a project. This took up a large period of our time, and it involves more than just one member of staff getting involved in that. And this isn't something that is just you do once. We have to renew our permissions to access this data. So it is a very time-consuming exercise that we've had to build in when we plan our study, both in terms of producing results and our updates. Secondly, it's not always been that easy to access our national and local expertise. Whoops, I seem to have lost my presentation there. Oh, it's back. Yes, it's not always been easy to access national and local expertise. For some disease groups, we've had great support from clinicians, and we've been able to access the relevant clinical networks, but for others less so. So we have to be aware of the limitations sometimes in our estimates there. And although our data coverage is wide in terms of our population coverage, the available data that we have from these administrative data sources is not always appropriate. For example, we have coding differences. For example, if we're looking to use our primary care records, the coding system used in our primary care does not match, is not that used, for example, in the GBD, the ICD. So we've had to do a lot of crossover mapping there. And even coding within these systems is not always perfect. So again, we have to be aware of the limitations sometimes in using these, relying on the coding within these systems. And basically, some administrative data sources are just not good enough to calculate certain conditions within a burden of disease study. For example, headaches. Almost impossible to use any form of health record to count headaches. Equally so, sensory conditions is not a particularly useful source for administrative data sources as well. And even though we are able to generate some severity distributions, I mentioned earlier we use it for cancer, we still rely greatly on the global severity distributions generated through the GBD process, and these have limitations themselves as well. But it's what you're handed. And yes, so just in summary, really, it's a mixture of both. It's good and bad. Being involved in the full process just allows us to be clearer about data capabilities of our data sources we're using, and both the limitations, and it allows us to be very open about those. And we publish disease briefings addressing each of the limitations specific to the disease that we're estimating the disease burden for. It's also allowed us to do some timely assessment of COVID-19 occurrence within Scotland, having this autonomy. And it's allowed us to investigate developing a disease model to describe the disease burden around COVID and to estimate DALYs around the COVID occurrence as well. And that has been a very useful process to engage with our policymakers as well around in this time. It also allows us to quantify a little bit the impact of underreporting and uncertainty independent of the methods. That means that we can actually make a kind of sort of soft assessment of how we feel, how strong we feel our data source is in estimating the disease burden accurately. And at the same time, doing it this way has allowed us to sort of synthesize our knowledge from our national study alongside the GBD efforts, the GBD efforts within their full cycle, to just facilitate a clearer knowledge, understanding and transmission to our policymakers and planners at local and national level, so that we can show maximum impact of our burden of disease result study. Thank you for your time this afternoon. Happy to take any questions.
Thank you, Ian.
Thank you, Henk.
I'm looking at the chat and I don't see any questions.
Okay.
Maybe I do have a question for you, Ian.
Okay.
You were mentioning that one of the issues that you have to deal with is the inconsistency between coding.
Yes.
Is your experience also that doing a burden of disease study, that it also has a feedback to, let's say, the data collecting organizations, that they also think of improving data quality and consistencies?
That's a good question, Henk. Yes, we do feedback our comments on some of the coding issues, but of course we are only one study amongst many demands on the national data collection studies, and whilst we feedback, whether that's taken on board is another question, and that's something that we pursue, but we're in a long queuing list of questions around coding accuracy within our system. What we can do is we can ask for a national data quality exercise to be undertaken. To date, we have not been successful in getting that done.
Right. We have another question in the chat from Dietrich Plus, who's asking how often you are currently able to update your estimates.
We can update our estimates annually.
Mm-hmm.
Yeah.
Yeah, and that's also what you're doing then nowadays.
Yeah, we'll update our estimates annually, but we'll probably only publish biannually.
Mm-hmm.
And we're looking into making some decisions we have to make about how worthwhile it is to update our YLD on a frequent basis.
Yeah. Okay, thanks a lot. Right, so then I suggest we move on to our next presentation. So that will be a visit to South Korea with Professor Yoon, who will be presenting us the work on burden of disease in his country.
Title is Conducting a National Burden of Disease Study in South Korea from Past to Present. Next slide, please. I have three categories for this presentation. First one is history of Korean National Burden of Disease Study. Second one is method. Third one is result and challenge. Next slide. first one is history of KNBD study. We started KNBD study since 2002, and then we have 4 turning points: 2002, 2007, 2012, and 2016. We increased in the target disease since 2002 from 130 to 260, and we modified the methodology for considering the Korean specific context. Next. We have 2 big grants since 2002. First one is first grant launched in 2013. The title is Korean National Burden of Disease Study. This project initiated by the Research and Development Project of the Ministry of Health and Welfare. This project funded by 5-year grant. And second large project launched in 2018. The title is the Korean National Burden of Disease and Health Adjusted Life Expectancy Study. This study also initiated by the same research organization, and this project funded by a 3-year grant from 2018 to the end of this year. Next. Our study, KNBD study, is slightly different from GBD study. Data from GBD are from a prevalence-based approach, but data from KNBD are from an instance-based perspective, and data from the GBD are for international comparison, but data from the KNBD measures the gap between subnational group income. We use detailed Korean data, and we, based on assumption relevant to Korea, epidemiology data reviewed by Korean expert, use of disability weight developed by Korean medical expert. We include subnational and socio-demographic estimate. So we have high level of transparency of input data. Next. Method part. Next. We have, as I already mentioned earlier, we have our own database. We use national representative data source, population, mortality and life expectancy, non-fatal health loss. For measuring non-fatal health loss, we used National Health Insurance Services claims big data and National Injury Hospital Discharge Survey from the Ministry of Health and Welfare. For measuring length of duration and age of onset, we estimate using this mode 2 program by WHO. Particularly for infectious disease, we directly calculated them using the claims data. Next. For disease and injury category, codes are structured with the use of 4-level classification hierarchy to produce levels that are mutually exclusive and collectively exhaustive. Hierarchical structure has 4 levels. For example, level 1 include communicable, non-communicable injuries. Next. For measuring cause of death, we redistributed deaths assigned to ICD code that cannot be the underlying cause of death. The proportion of garbage code deaths was 24.6% in 2010, 25.2% in 2012, South Korea. You can see through figure 2. Next. For disability weight, we used to estimate disability weight, which reflect the unique social and cultural context of Korea. Survey to derive cause-specific DW. We used a self-administered web-based survey improving our ranking method, and totally over 900 specialist participate. A total of 313 causes of disease were used in this survey. Next. This is a picture for ranking method from acne vulgaris to pancreatic cancer. Next. From now on, I will show result and challenge of our KNBD study. Our daily rate is steadily increasing. YLL rate is slowly decreasing, but the YLD rate is increasing. The growth in the YLD rate is faster than that of the YLL rate. The daily rate for females is higher than that for male. The gap between male and female is decreasing. Next. The leading specific cause of burden from 2008 to 2016, we can compare. For example, in 2008, self-harm is 10th ranking, but in 2016, slightly decreased to 12th. Next. And we can measure daily rate by income level. Q1 is the lowest income level, and Q5 is the highest income level. The higher the income, the lower the burden of disease. Next. And we can also measure subnational daily rate. There is a 2.2-fold difference between the highest and lowest daily rate. Low burden of disease in area with high income level. Left side picture is the map of South Korea. Next. So we can compare KNBD and GBD result. Originally, GBD result based on model driven, but the KNBD study result originated from the data driven. Ranking is slightly different. Daily rate is more slightly higher than GBD result. And as I already mentioned above, GBD based on prevalence approach to measure YLD. In this case, KNBD study used instance-based approach. Next. We have some challenges. First one, as I already mentioned above, perspective for daily, instance-based versus prevalence-based. We need research to estimate the distribution of health quality. Second one is database for measuring non-fatal health losses. In Korea, the coverage rate is high in the national health insurance system. However, mild illness, for example, migraine with a high OTC prescription may be overestimated. Third one is daily for small area. We will consider using a Bayesian spatial model. So, in conclusion, we will strive for methodological improvement to more precisely measure the disease burden based on strong data sources. Next. Thank you. Thank you for your attention. Okay. Question or comment?
Thank you on the work that you've been doing. A question from Dietrich Plus. Did you consider comorbidity adjustments in the Korean burden of disease study?
That's a good question. For considering comorbidity, we are now studying, and maybe at next stage from next year, we'll start new project for measuring Korean burden of disease study. At that time, we'll include that issue, comorbidity.
Okay, thanks a lot. And I was also wondering, what are your experiences so far with translating your findings into policy actions, so to inform the policymakers about these results and hoping that they will start acting upon these estimates. So what are your experiences with this?
We try to adjust our result to our policymaker. For example, in the field of mental health area, we published the comparison between the total budget of mental health and our the budget of our government for mental health. So we try to increase total budget for mental health area.
Yeah.
For
Okay.
example.
Thank you. Yeah, and as mentioned by Dietrich, it's indeed great to see such a historical development in a country. To follow up on such historical developments, if we can move on to our next presentation. So thank you once again, Professor Yoon. So then we have another example of a country where national burden of disease has been implemented since several years. So this is Australia, where we will have Michelle Gurley presenting on the work done in Australia to date. And for that, the presentation has been pre-recorded, so I can ask the organizer to load this presentation.
Today I'm presenting on key developments and results from the Australian Burden of Disease study. I'm presenting on behalf of my colleagues from the Australian Institute of Health and Welfare. Australia's been at the forefront of national burden of disease study development for more than 20 years. Australia's first study, conducted in 1996, was one of the first national studies carried out, and updates have continued to evolve over the last 20 years. The HW published our fourth Australian study last year, and the fifth study is currently underway. We've also completed 2 studies focused on Australia's Indigenous population, with a third underway. And all of these studies have been either carried out or had strong involvement from the AIHW. And for those that don't know, we are Australia's national leading agency for collecting, reporting and analysing health and welfare data in Australia. So my next few slides will focus on the Australian Burden of Disease Study 2015, which is the most recent published. It covered over 200 diseases and 38 risk factors. We produced subnational estimates at the state and territory, remoteness area and socioeconomic group level. We had 3 time points to enable comparisons over time. And we had a strong involvement from an overarching expert advisory group, and we also set up disease-specific and risk factor-specific expert panels. We built the system or database to enable efficient and ongoing updates into the future with each reiteration of the study. And our results were published mid-last year. We produced 3 reports and 2 interactive data visualizations. So looking at the methodological approach that we took, we largely followed the GBD framework. So we, for example, had prevalent YLDs, no age weighting or discounting, and we used a lot of the GBD inputs such as the disability weights and the standard life table. However, we did make some modifications to better suit the Australian context. For example, we had Australian-specific disease and injury lists and risk factor lists, focused on those diseases and risk factors of most relevance in Australia and of policy interest. We were able to make better use of direct, detailed Australian data, so less modelling required than the GBD approach. We often had access to unit record level data and linked data sets, and the majority of our estimates were calculated directly from the single best data source. 2 of our key method developments that we undertook was to develop Australian-specific redistribution methods for the YLL component. and we were able to make use of direct evidence available in Australia for some causes of death, as well as our high quality multiple causes of death data that the AHW holds. We also developed a data quality framework to describe the reliability and limitations of the estimates produced. This included a two-dimensional framework covering the relevance of the underlying data and also the methods used to transform the data into a form required for the analysis. And we developed a 5-scale scoring system in order to assess the relevance of the estimates. So now on to some results. So this slide here shows the leading disease groups causing both fatal burden, non-fatal burden and total burden. Overall cancer was the leading cause of overall burden as well as fatal burden, represented in yellow, and this was followed by cardiovascular diseases. And for non-fatal burden, musculoskeletal diseases, followed by mental and substance use disorders were the leading causes. And if we look at the 5 disease groups, top 5 disease groups causing burden in terms of the specific diseases, we found that if we look at the younger ages, asthma and some of the mental and substance use disorders such as anxiety and depression were among the leading causes of burden. Then suicide and self-inflicting injuries was the leading cause among adolescents and young to middle adulthood. And then coronary heart disease became the leading cause of burden from age 45 and over. If we look at our changes over time, we found that there was a 11% decline or improvement in total burden, and this was largely driven by a strong improvement in fatal burden. And that was largely driven by strong improvements in deaths and fatal burden due to cardiovascular diseases and also cancer. In terms of risk factors, we found that around 30% of all burden could be prevented or was due to the risk factors that we included in our study. And the leading risk factors were tobacco use, which was responsible for around 9% of total burden, followed by overweight and obesity, then dietary risks, high blood pressure and high blood plasma glucose. And cardiovascular diseases was a disease group strongly linked to all 5 of these leading risk factors. When we looked at our results by socioeconomic groups, we found a strong gradient in terms of burden from the lowest socioeconomic group to the highest across all of the leading risk factors, which is shown here in this figure. And we also found similar patterns when we looked at the diseases causing burden. When we did a comparison of our ABDS results to the GBD results, we found that our results were fairly similar when it came to fatal burden, but differences were apparent when we looked at the non-fatal burden or YLD. And this slide here shows some of the leading causes of non-fatal burden, with the ABDS results in blue on the left and the GBD results in red on the right. And we can see that for some diseases, GBD had quite significantly higher YLD than the Australian study. Falls is one example of that down the bottom, and also depressive disorders and hearing loss. Whereas the opposite was true for some other causes where the Australian study had higher rates of YLD. So some remaining challenges and opportunities from the study. We still have some remaining data gaps in terms of not sufficient prevalence data for some diseases. And this is partly being addressed in our current 2018 Australian update, where we've got better use of nationally linked health data, which will make some improvements to some of the chronic conditions. We are also looking at whether we have more data to enable more Australian-specific severity distributions. We know this is a key data gap, not only in our study, but also in other country studies and globally. Disability weights, we haven't done any work to date to look at either validating the GBD disability weights or conducting work to develop our own Australian-specific weights, but this is something that we're quite interested in. Similarly, we would like to do more local level estimates and finding the data as well as coming up with methods to do that. is something that we would like to do. There's also potential for a range of extension analysis from existing ABDS results. And we've produced quite a lot of work already where, for example, we've undertaken scenario modelling or projections to look at the impact of either reducing disease prevalence or reducing risk factor exposure, and what that would result in terms of changes in disease burden. So, for example, if current trends in overweight and obesity continue, how much burden would there be in 5 or 10 years' time versus a change made such as everyone in the population reducing their BMI by 1. Disease expenditure comparison. So in the most recent ABDSs, the HW has produced disease expenditure estimates in line with the ABDS cause list, so that a comparison can be made between the human cost on the DALY side and the health cost on the expenditure side. We're also assisting some researchers from the Australian National University who are looking at methods and plausibility of incorporating multiple causes of death in cause of death statistics more generally, but also in potential YLL calculations. And new risk factors such as climate change and social determinants also things that we would like to do for the next Australian study. So just finishing off on lessons learnt from our work so far, we think it's important to engage early and with a wide range of experts to get feedback needed, to keep abreast of international developments, not only in the global burden of disease study, but other countries undertaking burden of disease work, and to build a community of interest and share learnings and methods, to build and maintain staff capacity and set up a system or database to enable efficient and ongoing updates into the future. That will save a lot of time down the track and with each study. To seek stakeholder or user feedback on the reporting outputs, and basically to accept that burden of disease methods are continually evolving, and that it's a reiterative process, and that I guess no estimates are ever going to be perfect with the several million estimates that are produced from a burden of disease study. So thank you for your time.
With some key messages. So as nicely summarized by Michelle, we've seen that national burden of disease projects are very useful endeavors, also very challenging endeavors, but that the different countries that are engaging in such a process are often challenged by the same kind of problems and issues. So having a possibility to meet up with individuals from other countries who are also doing national burden of disease studies is indeed very valuable, and we aim to continue supporting these exchanges with our European burden of disease network. We've also seen that the global burden of disease study led by IHME is playing an important role in all of the national burden of disease studies, sometimes in a very direct way, sometimes in an indirect way, but it's always playing a key role. We've also seen nice examples, for instance, in Italy, where the national initiatives in turn can help to strengthen the global burden of disease study. So fostering this mutual interaction between work done at the global level and at national levels is indeed something that we should try to pursue in the future. I'm sure that you will have many more questions that you may also want to go through the slides again at your ease. So we have already made the different slides available on our website, so where you can have a look at the slides. If you would have further questions, please don't hesitate to contact the presenters directly. We are always very happy to be able to talk about our work and to exchange experiences and expertise. So with that, I want to thank all of you. So we had around 50 participants attending this session. It's a bit strange to coordinate an online session where we cannot really see the participants, but I want to thank you all for listening in, for the feedback that we got through the chat, and I wish you a very pleasant continuation of the conference and of all the other activities that you are probably continuing in parallel. So thank you very much. Have a good night for the people in the eastern part of the world, and have a nice afternoon and evening for the people in Europe. Thanks a lot and take care.